You can see that all right and hear me?
Yeah, perfect.
Perfect. All right. Hi, everyone. I'm Ash, if you don't know me. Today, I'm going to be talking about our work involving the preclinical development of an actinium-based radioimmunotherapy for pancreatic cancer. Sorry, the keyboard's not working. All right. So as you may be aware, pancreatic cancer is a highly aggressive malignancy. Currently, the 5-year survival rate sits at only 10.7% in Australia. And if you look at the figure in the centre there, you'll see that there's only been really minor improvements in that survival rate across recent decades. Currently, surgery is the only curative form of treatment available for patients diagnosed with pancreatic cancer, but it is limited to only 10 to 20% of patients with locally resectable disease. So about 80% of patients are ineligible for surgery at time of diagnosis. Instead, for them, first-line therapy is typically chemotherapy with or without the addition of external beam radiation therapy. Whilst this can help to prolong patient survival, it's not considered curative, so there is quite a significant portion of these patients without any form of curative therapy available. So that's where radioimmunotherapy can come into it. So this is a systemic yet localized form of targeted radionuclide therapy. The main difference being that we have a monoclonal antibody as our targeting vector instead of a ligand or peptide, for example. The antibody can be either a full-size antibody or just a fragment. They do have slight differences between them, but essentially when they're bound to a radionuclide, we get our radioimmunoconjugate. And that's designed to target a certain receptor or antigen, which is ideally overexpressed on your cancerous cells, but minimally expressed on normal cells, so that you can optimize the dose delivery to those cancerous cells. Now, one of the main factors affecting the choice of radioimmunotherapy development is between using an alpha or beta emitting radionuclide. So beta emitters like lutetium and yttrium are more widely used at the moment. However, there are some key differences in the physical properties between an alpha particle and a beta particle that lead to alpha particles having an increased biological effect. So alpha particles have quite a short range in tissue, but a high energy. Together, that gives them a high linear energy transfer, or LET. And essentially, that means that they're more densely ionizing. So if you see here, we've got those dense ionization tracks. The more ionization events we have, the more likely we are to cause double-strand DNA breaks, which are very difficult for the cells to repair and likely to lead to cell death. On the other hand, our beta particles are low LET particles, so they're considered to be sparsely ionizing. So whilst they could still create double-strand DNA breaks, the likelihood of them doing so is significantly less compared to the alpha particle, and that's what leads to those different therapeutic effects between the two. So in our work today, we have looked at both lutetium conjugate development, but today I'm just going to focus on actinium because it's kind of the up-and-coming one. So our work aims to target the mucin-1 receptor. So this is a transmembrane glycoprotein, which is over or expressed on the apical surface of your epithelial tissues. In normal cells, it has a role in cell signaling and some anti-adhesion properties. Now, whilst MUC1 is normally expressed on cells, when those cells transition across to cancerous phenotypes, that MUC1 structure undergoes some key changes that make it a valuable target for cancer-specific targeting. So if you look at this, what we call the variable number tandem repeat region, so this is the part of the MUC1 protein that extends beyond the cell surface, you'll see that that region is quite heavily glycosylated. That's what those pink things are aiming to show. However, in the cancer-specific form of MUC1, we have a hypoglycosylated region through there. So these amino acid segment repeats, which correspond to the epitopes that you can target, can only be targeted when we don't have those glycans there protecting that zone. So that's what leads to them being cancer-specific in that way. Importantly, the cancer-specific forms of MUC1 are also known to be overexpressed on most of our epithelial cancers, including pancreatic, but also ovarian, prostate, and breast. So there is potential that if our therapy works for pancreatic cancer, then we could also look at applying it to some of these other cancers as well. We've previously looked into the expression pattern of MUC1 cancer-specific epitopes on pancreatic cancer, and our study and a previous study have shown that it's overexpressed on over 90% of pancreatic cancers, which is quite a good expression level for this type of therapy. And importantly, the expression is also correlated with more advanced forms of disease. So there is potential that it might actually be useful for those patients presenting with the metastases as well. Our work specifically uses this C595 antibody, and so this targets this RP-AP region within that variable number tandem repeat region as well. So the overall aim of this study that I'll present tonight was to evaluate the feasibility of using actinium DOTA C595 as a treatment for pancreatic cancer. So we started off by obtaining actinium from Oak Ridge National Laboratory, I think in Tennessee in the USA. It was a difficult process, but we got there in the end. And using that actinium, we generally used around 3 megabecquerels of actinium nitrate that was dissolved in a hydrochloric acid solution and then incubated with our DOTA C595 conjugate. We only needed to react those two for about 1 hour, and we got quite good radiolabeling efficiency. As the actinium got older and underwent more half-lives, we did add in an extra filtration step to remove any unlabeled activity as well, but that was a bit few and far between. Then using that fresh actinium DOTA C595, we performed a series of cell binding studies. So for these cell studies, we had 4 pancreatic cancer cell lines listed here. And these cell lines were selected because they had different levels of MUC1 expression. So the PANC1 cell line had the highest expression of about 93%, all the way down to our ASPC1 cell line, which had 11.5%. So we wanted to see for this study whether the actinium was binding in a logical sequence related to that MUC1 expression. So using those 4 cell lines, they were incubated with the actinium conjugate in varying concentrations for 1 hour. After the hour was up, we removed unbound activity, washed the cells, and then we detached them from a well plate. And so this is an example of what the well plates looked like. The pink stuff, which you will hopefully be able to see, is the cell media. So that's what the actinium was added to, and that's what provides the nutrients to the cells while they're out of a body. We then collect the cell samples from that well plate and measure them in the gamma counter. And that initial study gave quite promising results where we saw that at concentrations of 50 nanomoles and above, that we had significantly greater binding of the conjugate to that PANC1 cell line. So that's what we expected and hoped to see. Importantly, there was a bit of a difference between all the other cell lines in a fairly logical pattern compared to the MUC1 expression. So with that information, we then moved on to look at how well the conjugate could be taken into the cell. This is important in terms of actinium because it does have quite a complex decay chain where it emits multiple alpha particles, multiple beta, and also gamma emissions. With the alpha particle emissions, there is high recall energies, and those recall energies could potentially lead to the daughter radionuclides detaching from the DOTA C595 conjugate. So if we know that the radioimmunoconjugate in the actinium form does go into the cell, then hopefully we have a bit of a way in containing those daughter products if that does actually happen. So it's just one step in that process to evaluate. So for this study, we had the same 4 cell lines, and they were incubated with a fixed concentration of the actinium conjugate. And then at different time points across the 48-hour period, we removed the supernatant, which contained the unbound activity, and then washed the cells again. We were then able to collect the surface-bound activity by applying an acidic wash. And so essentially that wash aims to disrupt the bonds between the antibody and the MUC1 receptor when it's only expressed on that surface level. And then we could collect that surface-bound fraction. Once the surface-bound fraction was taken off, we would then lyse the cells using sodium hydroxide, and then we'd trypsin the cells, which acted to detach them from those well plates, and we'd collect that sample as our internalized activity. And then both the surface and internalized fractions were counted separately using the gamma counter again. And so this gave some interesting results. Again, we saw in terms of the surface bound fraction, sorry, the mouse is not working too well. We saw that the PANC1 cell lines had the highest surface bound counts. Again, as expected, this was essentially the cell binding experiment just prolonged over a different time period. What you may notice is that the ASPC1 cell line did have higher surface counts compared to the other cell lines, which didn't follow our expected pattern of MUC1. But there are some key changes in the cell characteristics and binding behavior once they're in kind of the experimental setup and being assessed over a period of time. So it's not a too concerning result at this stage, but we'll see how it plays out in later studies. Then in terms of the internal counts, logically, the PANC1 cell line took in more of the activity because it was binding more at the surface as well, and similar with the ASPC1, so that can be kind of expected in that format. The total counts represent the surface plus the internal counts, thank you, which again follows essentially the same logical pattern as what we saw before. What we most cared about was this percentage of internalization over the 48-hour time period. And for all the cell lines, this was quite positive, irrespective of their MUC1 expression. So within 1 hour, we saw that each cell line had between 10 to 18% of activity internalized, which is quite quick when you consider that C595 is an antibody, and usually they have slower kinetics than some of our synthetic agents. And importantly, that internalization continued to increase over the 48-hour time period to a maximum of just under 50% for the PANC1 cell line, around 40% for ASPC1, and then CAPN1 and BXPC3 were around 20%. So they were lower, but again, we do see differences between the cell kinetics at these time points as well. So regardless, these results were quite promising in showing that it is taken into the cells and that it continues to accumulate that activity over time. Right, so with the cell binding and internalization assays performed, we wanted to start evaluating whether the agent could actually induce a cytotoxic effect. It's obviously important when you are assessing a therapeutic avenue. So in this study, we evaluated how well the actinium conjugate could induce gamma H2AX foci. So H2AX is a histone protein. It's normally expressed or found on your DNA, such as here. However, when a double-strand DNA break occurs, like we can see here, that H2AX protein becomes rapidly phosphorylated. And we're able to detect where that phosphorylated form of H2AX is using antibodies. So if you attach what we call a fluorophore to the antibody, then we can kind of assess exactly where those breaks are or how many breaks there are per cell. So it gives us a method of quantifying that. And as the gamma H2AX only arises in the case of double-strand DNA breaks, then this acts as a marker for assessing the direct DNA damage and the potential cytotoxic effects of the agent as well. So in this study, we did have to simplify it because we were running out of actinium by this stage. So we only used 2 cell lines, being the PANC1 and ASPC1 cell lines. They were treated with the conjugate for 2 hours. Again, we removed unbound activity, washed the cells, and then this time we incubated them again with some fresh media that didn't contain activity. And then at 1 hour, 24 and 48 hours after that fresh media was added, we froze down the cells. And that was so that we could stain them all in one go, rather than doing them individually, which could produce more error. So then all the cells were stained for the gamma H2AX using those gamma H2AX antibodies, which have the fluorophore attached to them. And then they were analysed using flow cytometry. So for those who aren't familiar with flow cytometry, here's just a schematic where we have our cells, which could contain either cells with the gamma H2AX or without, depending on how well the agent works. They will be filtered through the flow cytometer. and then they're focused down so that cells pass through in a single cell file. If they come down, there's then a laser light source, so that will pass through the cells. If the cells have the fluorophore attached, which is due to there being that gamma H2AX, then they'll fluoresce, and that fluorescence is then detected by the cytometer. If the cell don't have the gamma H2AX, they won't fluoresce, so then we won't get an event detected for that. And so we're able to quantify how many we have or what percentage of cells have gamma H2AX based on that principle. So for simplicity, I've just included the PANC1 cell lines here tonight. To orientate you, the red peaks through here, they're our untreated control cells, so that's what we're comparing to. The blue peak is our actinium-treated cells. And what we saw at 1 hour was that nearly 100% of all the cell lines had some level of gamma H2AX foci within them. So potentially about 100% of them had a double-strand DNA break within 1 hour of being treated. That continued at the 24-hour mark, where we didn't see any major changes. And then at 48 hours, we started to see a few changes. So primarily, you may notice that the percentage of positive cells for gamma H2AX decreased. 98% is still quite a high number, so we're not too concerned by that. But the major change was actually in the shape of the peak. So, excuse me, you'll see that the peak has widened out here, and it's also lost a lot of its height. So there's two potential reasons why that could be. Either the cells have repaired the damage, or the cells have actually gone on and died from the damage. So we don't have any method of establishing why it was at this stage, but it is something that we could look into in the future as well. But overall, these were quite positive first results for assessing the cytotoxicity. So overall, all our cell line studies have supported the use of our actinium conjugate as a therapy for pancreatic cancer. So our next steps are to finalise the in vitro cytotoxicity. So I have some clonogenic assays, which are more of a gold standard for assessing cytotoxicity. They'll hopefully be ready very soon. We're also aiming to continue to develop a diagnostic radioimmunoconjugate, likely either with copper-64, which we have looked at in the past. So then we have a bit of a theranostic potential to assess in the future. And if everything continues to be successful and subject to grant funding, we're hoping to progress further to animal studies and maybe one day a clinical trial, but we will see. I would like to thank Pancreatic, ANSTO and ANZ S&M who financially supported the project, as well as my supervisors in Eva, Dylan, Will and Will, Artem and Judy. And thank you for listening. I don't know if anyone has any questions now. If not, I will pass over to Dylan straight away. No? All right.
Thank you, everyone. Thank you for inviting us. And thank you, Alexis and Kathy, for all the good work that you've been doing. And I'd just like to thank Ashleigh, who's been an amazing researcher and PhD student, and actually a role model for anyone who wants to get into research. And she's had much success and even just recently won another award. Mine is a more clinical approach to pancreatic cancer, and it's using a phosphorus-based compound called Oncosil. I'd like to declare at the start that the Oncosil is provided to us by the Oncosil Medical Company, and they give us some technical advice through David James, who's their scientist. And these are collaborative trials with nuclear medicine, gastro department, surgery, and assay pathology. So as Ashleigh said, pancreatic cancer is a major cause of cancer deaths worldwide. And it's increasing in incidence a bit, particularly in Western countries. And the 5-year survival is really bad, mainly because it's diagnosed at a later time. So if you look at staging, if you get the cancer early, stage 1 or stage 2, when it's still resectable because it's largely still in the pancreas, then the outlook is quite good, but still guarded, median survival 12 months to 2 years. If you get it at stage 4, when there's metastatic disease, then the outlook is really poor at about 4.5 months. The group we are interested in are stage 3 cancer, where it's sort of in the pancreas, but it's lies very next to the major vessels. So how it is you can't quite operate then, but if you can reduce the size, it may be potentially resectable. So this is called locally advanced pancreatic cancer. Median survival still, when it's diagnosed, is less than a year. So this picture is just to look at management. If you get it early, stage 1, then you have surgery, a Whipple's procedure, where they remove part of the duodenum, the pancreatic head, and rejoin it together. It's fairly major surgery, but long-term outlook is quite good if you get it at this stage. Oncosil trial, we're interested in stage 3, where it's within the pancreas still, but it's very close to the major vessels. That makes operation difficult. Usually treated with chemotherapy, radiotherapy, and our assessment is looking at the role of Oncosil. If you get stage 4 disease, it's metastasized usually to the liver and nodes, and that has a very poor prognosis. Again, chemotherapy, radiation therapy, but this is where Ashleigh's research of targeted therapy is possibly to play a role. So what is Oncosil? It's made by the Oncosil company, who are Australian based. It's a phosphorus particle in a diluent. And these particles are big enough that they will stay in the cancer, but they're small enough so that we can inject them through a syringe. And the difficult part of this is that we inject it into the tumor, but to do this, you have to do it under endoscopic ultrasound, which is a specialized endoscopy technique where the endoscope has an ultrasound probe at the tip of it. So you do an endoscopy, then you use the guided ultrasound probe so that you can target the pancreas, usually through the stomach or the duodenal wall. There aren't many people who do it. We're lucky in Adelaide that Professor Nam Nguyen, who is our major collaborator in these trials, is expert at this technique. So this is the ultrasound, endoscopic ultrasound. That's the needle going into the pancreatic cancer. Phosphorus has a long half-life, 14 days. And the big advantage of this is that it delivers up to 100 gray to the tumor. This is a dose that you can't use external beam radiation therapy to, because it will cause too much collateral damage. So it emits beta particles, and that's how it works. So we first got involved because the company ran a multi-site trial, international trial, which involved 6 sites in Australia, UK, and Belgium, and enrolled 40 participants at these 15 sites. So this was really a pilot study to look at the safety, feasibility, and performance of using this particle injected under endoscopic ultrasound and comparing it to standard chemotherapy in locally advanced pancreatic cancer. So you had to have proven cancer, no metastases, tumor size 2 to 6 centimeters, good performance, and no prior treatment. We did baseline CT and PET scans. Here's a patient with pancreatic cancer, big lesion within the pancreas and irregular. We did the scans at the beginning and also at 3 months later. Exclusion criteria were if you had distant metastatic disease, pregnancy, previous treatment. And there was one which really covered the feasibility of targeting the tumor. Sometimes there can be a lot of vascular tissue around, And so at the time of endoscopic ultrasound, it's important to assess whether you can actually get in there, because you don't want to inject the tumor into the local vascularity. And so this was the sort of protocol. Patients have 3 weeks of standard chemotherapy. Then we inject the Oncosil week 4, and they continue on with chemotherapy for another 3 weeks. The dose of Oncosil is calculated on the volume of the tumor. Aiming, you can see it's not a very high dose, 6 megabecquerels per mil. And we looked at safety, progression-free survival, and also symptom pain control and things like that. So this started now 5 years ago. In this initial study, we enrolled quite a number, 7 of the 40 patients. Cancers were in the head, neck, and uncinate process. And median age was 66, so they're an older population. The Oncosil was delivered to our radio pharmacy a couple of days before the dose, because it's formulated in Germany. We then calculated the dose based on the CT volume. And the most important, or one of the more important part of this is radiation safety and the risk of contamination, because you don't want to contaminate the endoscopy theater, the staff, or more particularly the endoscopes with this, because with the long half-life, that will put it out of action for quite a few days. So this is a stringent protocol we have, checking for contamination of instruments and personnel after we do the injection, and disposable of radiation waste. And Ben Crouch has been instrumental in developing these protocols. As you can see, the injection volume is not large, average about 2 mils. So this is our RH radio pharmacy. That's the Oncosil. That's the syringes. We've got the Oncosil shielded with acrylic. And here's some water for flushing. And that's Will making up the doses on the morning of the thing. We usually do between 2 and 4 patients we can do on a morning. And this is the procedure. This is Professor Nam Nguyen. He's doing the endoscopy. Here's a patient. But he's looking at the tumor also using the endoscopic ultrasound. And then that's here, I am injecting it down the injection needle and taking great care to make sure there is no leak or contamination. So in this initial study, we were successful in all patients. And so far, we have had no significant radiation contamination, nor have we had any adverse effects. Each procedure takes about half an hour. But there are a lot of staff. There's an anesthetist, there are nursing staff, and everyone is gowned up and radiation monitors. After the injection, we do a Bremsstrahlung SPECT CT scan to make sure that we've got the injection in the right place. And with these initial study and subsequent studies, we found that nearly all the injection goes here. Because we flush extra radioactivity that may be in the line in the stomach as we are pulling the instrument out, we see occasionally a small amount within the stomach or bowel. So in this initial study, everything went well, no complications. We got about a 48% reduction in tumor size and pain score, which is pretty good for this cancer. 6 patients had resolution of FTG uptake of the 7. And what was more interesting in our group is that 40%, the tumor reduced in size so much that we were able to go on and get the surgeons to resect the tumor. And in 80% of these cases at pathology, no residual tumor was found. So here's a patient pre-Oncosil PET scan, Bremsstrahlung scan confirming we've put it at the right place, and then follow-up PET scan. And patients got good symptom control. So here's just a slide of surgery. You can see what it's done is it shrunk the tumor so that you can, so that it's a distance away now from the major portal and splenic vessels, which then enables you to resect it that you couldn't do when it was larger. Looking at the data from the 40 patients on the multi-site study, they got good disease control in 90%. Again, a good response, a reduction in size and CA19-9 levels. And in this larger group, they weren't as good as our smaller group, but about 24% underwent surgery because it shrunk enough. And again, 80% had no residual tumor at the time of surgery. And survival was improved a bit to about 15 months. But this is still early days. And the patients were followed for a couple of years, and we presented it last year. But there are many unanswered questions. So multiple factors will impact on tumor response and treatment. Chemotherapy, radiation, targeted therapy, vasculature can have an impact. And then, of course, chemotherapy agents and all sorts of other immune responses can affect how well the cancer responds to treatment. So we're very interested, and our further studies are going to look more at the cytotoxic effects, dosimetry, tumor vascularity, and effect on the stromal barrier. And we've been quite buoyed by our initial results because looking at the pathology specimens, using polarizing microscopy, we were actually able to identify the P32 particles in the cancer tissue. You can see these nice glistening areas here. So that enables us to then look at pathology samples or biopsies and get an idea of distribution of the tumor. We're also going to use endoscopic ultrasound and quantitative ultrasound after injecting a small amount of air bubbles. You can then visualize the vascularity of the tumor. And we're going to use variable established criteria to look at the impact of the treatment on the vascularity. We also want to look at the injection therapy. If it's a small lesion, we just inject once. But if it's a larger lesion, we're going to inject sort of in 3 levels and see whether this has an impact. And we're going to do a study looking at Oncosil and FOLFOX chemotherapy versus FOLFOX alone, because this has become more the standard of chemotherapy. So we're just getting ethics approval for a study, and this will be the only study run by Oncosil in the world of 52 patients. 26 will have chemo alone, 26 will have chemo and Oncosil, and we will monitor them for up to 2 years to look at survival, adverse events, and response data. And there will be other secondary endpoints looking at safety, progression, and various other clinical scores. So we're just starting on these studies at the moment. Ben and Maddie have come up with another very interesting trial, because when we do the Bremsstrahlung scans, we'd like to get more data, whether we can look at distribution and dose, how much dose actually is there. And so Ben has started phantom studies using a NEMA phantom to try and get some data on this, and the initial results are promising. We're also putting a project through. Amanda Lim is a gastro fellow who is doing a PhD on this. And this is looking at the role of maybe injecting isolated JEPNET cancers within the pancreas, grade 1 well-differentiated tumors with Oncosil, and seeing if there is any impact on this. But this study needs to go through ethics and all that at this stage. So our experience so far, off trial, we've done about 30 successful implants. We haven't had any complications or radiation events, thank goodness. And we've been acknowledged by the company as a site of Oncosil training and excellence. So in summary, in locally advanced pancreatic cancer, Oncosil is safe. We've seen good symptom and local disease control. Interesting data on reduction in size of the tumor. And 24 to 40% were downstage to the extent that we could then go on and perform surgery. So this is quite impressive data in a clinical setting, but has to be taken with a pinch of salt because these are only small numbers of patients and we're awaiting long-term outcomes and other data on distribution, injection technique, and perfusion. So as with Ashleigh studies, a lot of people are involved in this. Nam Nguyen is the endoscopic ultrasound expert, and this is the main thing with this. It's really dependent a lot on these skills to, unlike targeted therapy. And these are all our oncology staff, many of our nuclear medicine staff, and I should mention Maddie Bills, because Maddie has been observing and learning to do the injections, and is in a position now to do some of these Oncosil injections uh, when I may not be able to do them. And of course, it involves the whole team in radiopharmacy, physics, endoscopy, and the surgeons. So thank you very much. And I guess we're open to any questions.